Okay, so I was sent some questions, few questions, and so I'll just read the question and then we'll just give answers or explanations. And if any one of you has got any query and want to chat, please feel free to do that. Okay. So there was a question saying, why do some candidates fail MRCOG Part 3 despite good preparation? The simple answer is in here is knowledge versus performance. Okay, you guys, and I always say in my lectures, whatever lectures I've done so far, and in the beginning, I always say, you guys have knowledge, superb knowledge. Okay, much more than myself, but it's actually the performance that's important. Okay. Uh, the common real reasons for failing this exam is, in spite of you guys having fantastic knowledge, is that because the answers that you give, the question which is outside on the booth, and you read it and you come inside, you give a very unstructured answers. You know a lot. The content is overflowing, but delivering it is like a ramble, right? So you know it, but you want to just come and regurgitate your knowledge as if you are reading from a book. The examiners don't need that. You have to formulate the answer according to what's been asked you. Okay, so first of all, you have to structure the answer that you give. For example, there is a case of patients come with menorrhagia, okay, and the information is given, she's unmarried, she's been bleeding as so and for how long and all that. When you come, you basically structure it. What brief other things you're going to get from the history? Okay, has she got sort of any? Has she had any previous? She has got any medical problems, for example, bleeding disorders and other problems. Has she taken any medication to improve it? And first, you want to get the information first. Okay, then you can formulate that what options you're going to give, right? So important is you got the information, then you do the examination, you do the assessment, then you discuss the options, okay, and then get the patient involved in the decision making, and then give the treatment. So that sort of way of explaining it gives a good impression to the examiners that this candidate is well has got a good grip of how to deal with the patient, not to regurgitate the textbook in front of me. Okay, so that is number one. Also, there's poor prioritization. They list everything. The candidates list everything instead of what matters. Okay, what examples shall I give you? Okay, yes, a patient has come and she is what to say? Uh, really, what I mean to say is, you guys, even when it's not needed, okay? Yes, good example. In one of in the station, there was a question. The patient is 38 years gestation. She's 38 weeks, sorry, pregnant, and she has come and she has got some discharge, right? Bleeding and discharge. Now, the question says by dates, it's confirmed, by ultrasound, it's confirmed that she is 38 weeks of pregnancy. Now, the candidate is going through the list of, menstrual history. When was your last menstrual period? And then, okay, fine, last menstrual period you want to confirm, but then, were your periods regular? Okay? There was no need for that. So you go through the menstrual history, you're asking, how often you get your periods, if periods are regular, okay, how's the flow, last menstrual period, up to date with cervical smears, and all that. That is a list that you're going through. You have to put the stuff to that particular question. So this case, like 38 weeks pregnant, why do you want to know whether her periods were regular or not? Okay. Why do you want to know her a cervical smears? It's related to hair. Okay, they are specifically asking. She is come with a maybe APH. Okay, so you have to ask about the pain. She is sort of has she had a previous scan? Was the placenta found to be low and all that? Those are the prioritization that you have to do, particularly for this case or scenario which is in front of you. Okay, then is the weak communication. It's unsafe tone. There's no empathy. The candidate doesn't show any. They're using jargons, heavy medical jargons, in case of counseling. And if you're delivering like bad news, there's no empathy, Naraka. There's no empathy. You just sort of basically verbalize it. So that's number 3 is a weak communication. Number 4, you ignore the task. For example, managing when asked to counsel. So the question is asking you about counseling the patient about fertility options, counsel the patients about getting HPV vaccine and similar things. So you do not ignore the task. Number 4, lack of senior decision making. Okay, this question is not that you are dealing with this case as if you're a senior. I know lots of you in your country are performing and working at a much senior level, but the MRCG is for a year three SHO level, okay, not a consultant or a senior registrar level. So you have to involve seniors or consultants in your decision making. Time mismanagement, that is crucial. And I, as an examiner, I have seen people taking 3 to 4 crucial minutes, sometimes even 5 minutes on history taking. I gave you the examples of why do you have to take all the history, okay? Asking even that 38 weeks pregnant, is your partner supportive? Have you any history of what is called drugs intake? There's no relevance to that. You just formulate your history in relation to that scenario that's been asked from you. Also, failure to verbalize safety means escalation. There are red flags. There are, some things which you need to highlight, and documentations. For example, you did a PPH, okay? You dealt with a postpartum hemorrhage. A patient bled liter, 2 liters, and you manage that patient's, then you have to come in documentation, right? So don't forget that you will come and document what happened. And because these cases, they are medical, they could turn into medical legal cases. And if you don't have a proper documentations, you won't have a leg to stand on if these cases come to go to court years and years later. Also, involvement of multidisciplinary team. So, for example, if you're dealing with a PPH, don't forget you have an anesthetist. Don't forget your blood bank. Don't forget you have the senior. Don't forget you have others' involvement. Similarly, if there is a patient who is antenatal and has got any medical disorder, involvement of the physician. If she's got a cardiac problem, involvement of the cardiologist. Okay. So the bottom line for this question is that many well-prepared candidates, they prepare the content, they know very well the content, but the delivery of that question or answer is poor. Okay. Any comment or anyone asks anything on this question before this answer before I move on to the next question? Okay. So the next question was, how do examiners tell the difference between a pass and a borderline result? To be honest, when a candidate comes within the first 3-4 minutes, I know which candidate is pass, which candidate is borderline, and which one is fail. Okay. We look for consistency, we look for safety, and we look for clarity. Okay. If a candidate is coming and is just going from one end to the other without any structural formulation of the answer, for me, that's a failed candidate. For me, a pass candidate is the one who gives the answer in a structured and calm way, okay, and identifies the key risks early. Okay, what are the risks? What are the benefits? Also makes clear decisions, right? Not rambling or on sitting on the fence. It gives me a clear answers of what decisions would be. Okay, they use guidelines appropriately. I do not want that you verbalize the guidelines to me just like that, but you can sort of as per the guidelines, right? He knows the guidelines, but not just throws the words in there, and use structural approach. Okay. Also communicate empathetically. For example, in cases of breaking bad news, the body language, the way they talk, the way they communicate with patients, not just sitting arrogantly and just talking as if they are giving a lecture and not dealing with the patients. Okay. They have a focused history taking, and you can tell right from the beginning that this candidate is very literally the plan is very clear in this candidate's head. It's not a chaotic jumping from here to there. Okay. And also escalates appropriately, for example, involving the consultants, involving the senior, involving the MDT approach. So that is what a pass candidate would be. In case of a borderline candidate, says it's like in those who are hesitant, they overlist, they miss prioritization, and they are unsure or unsafe, and they need a lot of prompting or escalate, or sometimes because examiners don't talk, we are not allowed to talk. But if it's a role player, the role players have got some questions to ask, and there is instruction that if the candidate is going on it in a tangent or again going through a wild goose chase, try to ask this question to bring them back onto the track. And in that case, if the role player is prompting the candidate too much, then that is a borderline candidate for us. What instruction is to us, and what sort of I do as well, and most of my other colleagues do, that would we trust this doctor with my patients at 2 o'clock in the morning? Okay, if I leave this doctor on labor ward, would I trust this doctor? If the answer is yes for me, then that candidate pass. But if we think maybe, that's a borderline, and if definitely not, that's a fail. That's how we do, and we, in our experience, we can judge that very, 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 very quickly. So at the end, we have to give a global score of a pass, borderline, and fail, and that's what we base our answer on. Okay, anybody wants to talk to me? No? Okay. Did that answer your question, whoever asked this question? No? It's radio silence? Okay. We go through the next question. How much guideline knowledge is needed for counseling and management stations? I would say high level. It's a practical knowledge, not memorization. Okay, so you need guidelines. Guidelines are there for your guidance. And most of the practices that do is based on guidance. Okay, you are not expected to quote, I wouldn't say that you have to quote the paragraph, you have to quote the number, you have to quote the page number. And if you see the guidelines, it's quite extensive. But most of the guidelines, if you see the green top guidelines on RCOG, it gives you maybe 1, 2 pages of explanation and evidence base on different studies about something. But at the end, there is a line. It says that as per the RCOG guidelines, this should be recommended. And that is enough for you. Okay. But all the different studies that they're given explanation is telling you that yes, the guidelines have not just been made in a day or 2 days. It's taken, the reviewers weeks and months and sometimes years to produce guidelines. We work very hard on these. We go through different studies. We look at all different studies across the world, and then we make these guidelines. So, of course, the guidelines you should know. And what is expected that you give the correct principles. Okay. For example, in guidelines, it's a conservative versus surgical management. For example, a patient has come, she is a miscarriage. Okay. A good candidate, I would expect that they give the options of treatment: conservative management, medical management, surgical management, and give pros and cons to each of these managements. Similarly, when you are doing, salpingectomy versus salpingostomy, okay, management of ectopic, conservative medical surgical management. So that's how, if you formulate your answers, and these are also based on the guidelines. The thresholds, for example, where there's relevant, for example, a threshold of blood pressure, at what threshold you think it's, in preeclampsia patients, threshold of hemoglobin, at which threshold of hemoglobin that you need to treat patients, whether you give them hematinics or you give them blood transfusions, or you deal other way. Again, the gestation, at what gestation you feel that this, the patients need to be treated for certain things. Options, risks, and benefits. Okay, these are also part of the guidelines, and also it gives a good impression to the examiners that you are very clear in your head regarding treatment. So always include the options. When you give the options, each an option should be given with its risk and benefits. It's an RCOG, it's a UK exam, so you should be aware of the NICE and RCOG guidance, okay? If you are saying something, if you're quoting something, then say as per national guidance. It should be, you should say it confidently. And the national guidance are the NICE and RCOG guidance. The candidate where the candidate loses marks is that when they start quoting guidelines, overquote it. Okay, all the time guidance. So that sort of tells the examiner that this candidate is trying bluffing and is trying to hide behind the guidelines. Also being very rigid on the guidelines. Okay, the guideline says no. There are certain things that, okay, as I said in the beginning, that the guidelines are for your guidance. Okay, you should not be very rigid, because I had seen some candidates be arguing with the examiners, and that's a very dangerous thing. And also, sometimes you overuse it, saying guidelines to avoid thinking. Okay, so guidelines, in short, it supports your judgment. They don't replace it. And as I always say, guidelines is for your guidance. You can use it for your guidance, but don't overuse it. Okay. Anyone want to say anything before I move on to the next question? Hello? Okay. 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 So the next question was asked, how should answers be structured to quote? Just a second, let me get the light. How should answer be structured to score well in all station? It's important that you use mental template. Okay, we examiners love predictability, right? For example, if there is a management stations given to you, okay, how would you manage this scenario, or how would you manage whether it's an emergency or whether it's a normal case? So the mental template that for this you should use A, B, C, D, E. Okay, so A stands for acknowledge and assess urgency, right? So if the patient has come for, let's say, bleeding, okay, menorrhagia. So you know what the history is, and just sort of assess the urgency, whether she is bleeding to death or she can be managed conservatively. Okay, so you need to assess that and acknowledge. Okay, and then you check the background. Background is that, what are the key facts, right? What could be the cause? Is she, she has an injury, or this is a period, or, she's pregnant? That sort of the background you should put. So A is for acknowledge and assess urgency, B is for background, then C is for clinical assessment. Okay, so you assess her clinically. Again, inspection, palpation, and, assessment, all that. And after that, when you have assessed her, then you definitive management. How do you gonna manage this patient? For example, she's a 30-year-old, she's come with menorrhagia. Okay, there's no urgency for her to be admitted or blood transfusion, but it could be managed, and you did the examination and you did the ultrasound, and it's management. You can treat her pharmacologically. Okay. So that is where the D comes, a definitive management. E is escalation and documentation. So, for example, if this patient she was a 60-year-old, she came with heavy bleeding, in that situation, your management would be different compared to a 30-year-old who has come with a normal period, heavy menorrhagia. So E will be escalation. You will escalate her to your seniors. You will escalate her to the rapid access cancer clinics, and also then the documentation for these cases. So this is the A, B, C, D, E is for the management station. Then comes if you're dealing with a counseling, okay, for example, patient who has a miscarriage, okay, you use the EORSP. It just sort of we made it, and it's easy to have the mental picture and remember things. So E comes for empathy, as I said in the beginning. The candidates, they don't show that empathy. Miscarriage is a loss, right? So you should be empathetic. This patient could have been trying for 10 years of fertility, and then she got pregnant and miscarried. It's a big loss for her. Yes, empathy or sympathy is not sort of for patients only where there is, God forbid, death involved. This is also a big loss for the patient. So empathy, E stands for empathy. O stands for options. So options in this case is if she's got a miscarriage, give her the options of, treatment options of conservative. Patients may not want to go for surgical management straight away or medical management. She wants to give time to absorb things. So that in that case, you can give her the options of conservative versus medical and surgicals. And then each options, you should give the risk and benefit. If it's a conservative, you can say that, sometimes the pregnancy stops, the body recognize it as foreign, and ultimately the uterus will start contracting and will start getting rid of this pregnancy. So the benefits are that you would not need any surgical intervention or medical intervention. It will occur naturally. But the risk involved in this case is a small risk, is that there could be products of conceptions left behind, or there could be risk of infections or risk of heavy bleedings. So that's how you give the options to the patients. Also, you talk about the shared decision. If this patient has been trying for a long time, had a miscarriage, you can sort of say, I can offer you to see our fertility specialist, IVF, options of IVF. Also, I can, get my seniors to come and speak to you, okay? And then you talk about the plan and safety net. So EORS, plan and safety net, okay? So and also, whenever you're doing this, saying things like, I would prioritize. Okay, for example, when you are on a labor ward board, you are given some patients need urgent, immediate attentions. Then you say, I would prioritize this case. I would ask my SHO to go there. I would ask my midwife to go there. Okay. Also, the immediate concerns. Some cases you need immediate concerns. You would prioritize. There will be immediate concerns in some cases that you go. Also, you can say that I would explain this in simple terms to the patients. As I said, that you should not be using jargons there. So explaining to the examiner that you will talk in simple, you explain this in simple terms, and also that you will involve your seniors or consultant in the decision making. So always, if you structure your answers, that will fetch you more marks. Okay. Anything else? Before I go on to the next question, anybody wants to speak to me? Maybe not. By the way, those people who have asked this question, are they present in this? Okay, maybe not. Nobody wants to talk to me. At least somebody can say hi. You just want to
Hello,
see me in
ma'am.
the exam? Hello, who is that?
It's Faiza.
Oh, very nice. At least somebody's talking to me. There's not radio silence. It's like as if
Yeah,
I'm talking, I'm just talking to the computer here.
yeah, ma'am. We are listening very actively to you, very deeply involved.
Yes, that's great. That's great. So are you absorbing anything, or is this making any sense?
Yeah, ma'am. Listening and absorbing each and everything.
Okay.
Yeah, I'm a candidate for a May MRCPI exam, inshallah.
Oh, you're the MRCPI. Okay. In
Yeah,
May, inshallah.
yeah, inshallah,
You
ma'am.
you will
Uh,
do
well,
well.
I yeah, I have a question. Uh, when at some station there is no patient and we have to interact directly with the examiner,
Mm.
and we have to explain something. So we will talk like we are talking to a patient, or we will talk to the examiner and we will tell that I will do this with the patient, I will do this, and I will tell this, and like what will be
Okay.
the way of communication with the examiner?
So see, there are a number of times that we have to act as a patient. Okay, so in the beginning, just sort of say, uh, "Do you want me to talk to you as if you're a patient, or do you want me to explain to you as the way I will explain to the patient?" And the examiner will tell you. Okay. I really, I had a couple of stations that I dealt with an exam with patient, and there's one or two candidates asked me that. And I said, consider me as a patient. That's it. So there's no right or wrong. And if you just sort of, if it's saying on the question that the examiner will be your patient, then deal with the examiner as the examiner is your patient.
Okay, thank you, ma'am.
Okay. Okay. So so now I know that there are people listening, so I can I can go ahead and talk, get to the next question. Okay. So the next question was, what actions or words can reduce marks immediately? In my opinion, these are called silent killers, okay, which will reduce your marks immediately. And what are the silent killers is, uh, I don't know. Okay, the moment you say I don't know, that's you got it. So instead, you can say, I would check the local guidance, or I will discuss with my senior, or I'll discuss with my consultant. So if you don't know anything, don't say, I don't know. Just sort of say that will give me, that will give me an impression that you are a safe pair of hands. You want to know about it, so of course you will go back and check the guidance. You will go back and speak to the senior. And all the time, we don't expect you to know everything, right? it's very much acceptable, and at your level, we do want you that you should get the senior opinion or go and check the guidance. Sometimes, I won't remember what the guidance says, what the guideline says. I'll go back and check my guidelines. Chanda AC look. Okay. The other is ignoring patient distress. I have seen there's a patient there. She is a stillbirth. She is in distress, right? And the candidate is talking, just verbalizing and regurgitating what he or she is doing, but not listening to, not looking at the patient distress. Okay. And there was it's from my experience ages ago. I was doing an MRCOG course myself, and at that time, and I was in a just a, just a second. Okay, so sorry, I did not know there's other mentors. So can I just stop there and other mentors can talk? Dr. Manjir and Dr. Lala, can you just come, please? And then I will hold on here. Sorry, I did not know. I thought it's only me.
No problem,
Doctor.
ma'am.
So I think you should have clarified this. I thought, it's only me. So can the other mentors please, because
Yes.
nobody identified themselves.
Dr.
Assalamu
Lam.
alaikum, Dr. Yasmin. Dr. Leila here.
Hi, Dr. Lela, how are you? Oh,
I'm
thanks
good,
God that
thanks.
he is there. I thought, they want me to talk.
And I just listened to your Pashto words.
Oh, really? You can see
Yeah. Because I'm
you
also,
also?
yeah, I'm from Mardan, so that was good
Oh,
to know.
oh, really? That's great. That's great. No, okay. So I will hand you over now. Can you talk
Thank you
now?
so
So at
much.
least, but I thought I'm just talking to the computer myself.
No, I
No,
just
and
joined,
I'm
and
also here. Yeah, salam
who
alaikum.
else is here?
Bye,
Yeah,
Salam. Who's
I'm
that?
Khabar. I'm Khabar from Riyadh. And I've been listening to
Oh,
you also, Dr. Yasmin. Very nicely you have explained and pointed out the common mistakes and how they can improve and what things they should do or not to do.
brilliant. Yes,
Yeah,
thank you very
so
much. I think I thought
yeah.
as God, my God, as I'd be talking and nobody is communicating with me. So please go ahead, and I think I will, Dr. Leila, you can start, and then Dr. Khawar, you can, and then Dr. Manjir and Dr. Musarrat is there as well.
Yes, Assalamu alaikum, Dr. Yasmin. I am Musarrat
Alaikum assalam. How are you, and where are you calling from, Dr.
from
Musarrat?
Lahore, and I was listening to you very keenly. Today.
Everybody was listening. Nobody was saying that, please, we are here, or raise your hand.
No, actually, the candidates are, we were expecting that they will get involved because you are answering their questions, actually.
Yes,
And we all have a
I
set of questions to answer. So we were
okay, so
expecting that some students may come up and
okay.
respond to whatever you were telling. But you very rightly
Nobody,
said that there should be a structured approach, and time management is crucial for part 3, of course. And we take
yeah,
long time for history, keep on talking, and then in the end, there's no time left. Yeah, you are
yeah.
right.
So it's the thing is that what I think I was given these 4 or 5 questions. So
Yeah,
I'll finish with the final questions where I said the silent killers. For me, the silent killers are I don't know, ignoring patient distress, not escalating when required, unsafe reassurance, blaming the patient. There are people who are blaming the patient as well, being very defensive with the examiner, overconfidence and cocky, that does not go well, and also forgetting consents documentation or MDT input. So basically from my side, and I'll hand you over, you can answer the other questions as well. MRCOG is not an exam of brilliance, okay? It's an exam where we want safe, senior, structured practice under pressure, because we deal with all these emergencies and we want very, very structured practice in these cases, okay? So with that, I will hand over to my other mentors and I will now nicely, quietly listen to what Dr.
Okay.
I can have a coffee now. Yeah, I can enjoy my coffee.
Okay, thank you
Yeah.
for your time, Dr. Yasmin, and a very warm welcome to all the students for joining us in this Q&A session today from MedExam Expert. I'm one of the mentors for MRCOG Part 3, and I have also been assigned some questions which I'm going to answer the students. But before that, I would like to share my experience which I had with some of the students in the one-to-one mocks which I had for the November exam. And some of the mistakes which the students made. So I would just like to share my experience so that we all can learn from the mistakes that those students made and to avoid such mistakes. Right? So we will start from the very beginning. We'll talk about the first 2 minutes time, right? So what I experienced is that actually the 2 minutes time is very crucial. In these 2 minutes, you need to actually analyze your station, that what is the gist of the station, what is the station actually about, and then make a structure of what you are going to speak in the next 10 minutes, right? So the analysis of your station in these 2 minutes is very important. And first thing first would be just carefully reading that whether it is a structured discussion or simulated patient task. Because I experienced that in some structured discussion, the candidate would start talking to the examiner as if they are patients, right? So make sure that you have situational awareness, that where you are, which place you are in, which clinic or emergency ward or whatever you are in, and also whether it is a structured discussion or simulated patient task, right? And then analyzing your station is very important. Then coming to the 10 minutes time, in the 10 minutes time, make sure that you have a very short and crisp agenda. I have listened to students, and I timed them, and I'd seen that they would the agenda would be taking 3 minutes. One of the student, she finished her agenda in 3 minutes, so that is too much time, right? Make sure that you make some lines for yourself. There's no need to, like, be to like the agenda need to be very crisp. What I have learned from one of our senior mentors, Dr. Shazia, was that she would say that what brings you to the clinic today? And that's it. Like these are some wonderful lines which you can use to avoid wasting your time, right? And then getting to the history taking, because that is your main information gathering, right? So in the history taking, I have seen the students that they have a template and they want to finish the complete template. They want to ask every question which is included in their template, right? So we are not going to do that. In the history, the history should all be about the analysis of the complaint, the main complaint which the patient is coming with. So analyze that complaint, or ask 3 or 4 questions about that complaint, then ask about the causes and any risk factors, right? So that's it. And in the past history, some important questions which are relevant to your condition, only those questions, right? So no need to ask about social and mental history in every other station, right? You can skip these in the emergency situations. Then I also experienced that candidates were not very well structured in their presentation. Like one of the students in the first station, that when she came, she her agenda was too long, and then she came straight to the management part. She in the tension of the exam or in the stress, she just skipped the complete history taking, right? Or some would be going in the management, they would be going from one point to another point rather than being structured, right? So this is what we teach you guys in our live sessions when we take you through the different modules. We listen to you and then we correct you, right? So how we are going to take a targeted history, that is very important. Right. So these were some important points. And then, of course, Dr. Yasmin also talked about this, that we need to be very thorough in our guidelines, because what I'd seen is that candidate wouldn't understand a station. For example, there was a station which was about unexplained infertility, but the candidate thought that this was an ovulation because she thought that the progesterone levels are not within the normal range. So this is a very basic thing, right? Everyone who is taking the exam, or even if you're a clinician, you need to know about the progesterone levels, especially for the exam. Just go through your guidelines. So you need to be very crisp in your guidelines, right? Make sure that before the exam you go through the summaries of the guidelines once, and know these basic points. There was another station in which one of the students, she didn't calculate the RMI correctly. It was about I think a postmenopausal cyst. So if you don't correctly calculate the RMI, your management plan would be different, right? So make sure that you are very thorough in your guidelines so that you pass the applied clinical knowledge. Also, you need to get the gist of the station, right? So that was all about that. Now I have been assigned some questions, and I'm going to answer them one by one. So the first question was that what is the safest way to handle emergency and high risk stations, right? So in these stations, uh, these are mostly about patient safety. You need to be sure that even in all the stations, you need to make sure that you are incorporating like 2 or 3 points of patient safety in there. But in these emergency stations, it's very important. So I would say in the management of these station, you make sure that first of all you call for help, right? This is an emergency situation. You need to have some personals. Of course, you need to inform your consultant, and then whoever is there on in emergency with you. So call for help is very important in these stations. And then the safest approach would be to start with ABCDE approach: airway, breathing, circulation, the simple things, right? So these are the things which is going to save you. Then I have seen that in the emergency situation, a candidate would be ordering some investigation like a CT and this and that. What we need to do is to start with some very simple, immediate steps which we are going to take to save the patient in that situation, right? Um, so if the patient is bleeding heavy, what you are going to do: airway, breathing, circulation, maintain 2 wide bore IV lines. So these are the basic things. Connect oxygen, and then of course, for example, if it is a PPH, then start with emptying the bladder by manual compression and all that. So immediate steps and then further steps, right? So in these scenarios, keep this in your mind. Then another patient safety in these situations would be addressing the issues of clinical governance. So after managing the station, you need to make sure that you have raised an incident report on DATIX, and debriefing, documentation. All this is important, right? So that was all about uh, tackling emergency situation. Then the next question was, how detailed should the management plans be in a limited time? So, how detailed? Um, you basically need to, for example, if it is an infertility station, you need to give a management plan. So, for example, I would again take the example of that station, the unexplained infertility that is coming in my mind at the moment. And the main concern was that it was unexplained infertility, but then the patient was ovulating, and the patient has quite a significant BMI, right? So that would be the main concern. And most of the time, the role player will tell you that that is the main problem, or it would be mentioned in the candidate instruction. So make sure that you address that point first, and then of course address the other issues which are there in your station, right? And one trick would be to start your management with a multidisciplinary team and name all the members of MDT. So that would pass you for the communication with colleagues domain as well, right? And so for all these management plans, of course, once again, we need to be very thorough in our guidelines. So we give the correct management to the patient, right? And then there was another question, that how should candidates show leadership and escalate cases if needed? So this question can be mainly about the prioritization stations, in which you are one of the ST5s, and you have taken charge of the labor room, and then you need to prioritize, and you need to assign tasks and delegate tasks. So in that situation, showing your leadership skills is very important, because taking charge and of the labor room, and then making the correct decisions. So which patient you are going to see first, which patient you are going to see yourself, right? That is important. And you need to know that when you need to call for help, when you need to involve your seniors. And then of course prioritization and correct management of all the rooms or all the stations which you have been given, right? So I think that's that is how you're actually going to show your leadership skills. And uh, of course delegating appropriately. Then there was a question that how many mock exams should we take before the real exam? In my opinion, I think one on-site mock exam is very important, because you need to get a rehearsal of before the exam, of how the exam is going to be. So I would say a one-to-one mock is also important, but on-site mock is equally important. In one-to-one mock, examiner can give you more time, and they can assess you for a station and give you feedback there and then, and they can give you detailed feedback, and you can ask as many questions as you can, which might not be as much possible in the on-site mocks. So that is my opinion. And I would also like to ask Dr. Yasmin to give her expert opinion here, that how many mocks should the students take. Dr. Yasmina, are you there?
Yes, I'm very much there.
Okay.
Okay. Thank you very much for that. It was very good, and you gave all the points and things that one should consider, and the mistakes that the candidates are doing and should be avoided. Now, in terms of how many mocks you should be attending, for me, I feel that every day you should be practicing it yourself with your colleagues, okay? And I always say to the candidates that when you come to the exam, I know it's difficult, but forget that you are in the examination. Forget that you are in front of the examiner. The examiner, just consider the examiners as a fly on the wall, right? Deal with the patient as if you are sitting in a clinic, right? If you do that in your day-to-day thing with your colleagues in front of the mirror yourself, you just need one mock, course, maximum 2 courses, not much. The courses is not there to teach you the last 3-4 years of your practice. The course is just teaching you how to polish it and how to formulate your answers and deal with the patients. This is all you have learned over the last 3-4 years of or 5 years of your practice in obstetric and gynecology. So you should be practicing it daily. I have seen candidates who are repeatedly doing it. They get together in groups with one or two of their colleagues and repeatedly doing that. And they benefit from that, or sit in front of the mirror and do it. So there's no right or wrong answers of how many courses you should attend. For me, I think once you're fully prepared, you attend 1 or 2, and that should suffice for you.
Yes, exactly. So, taking, I think, too much courses and then just learning new things towards the end of some students, they are, just taking every other
Yes.
course from every other
Yeah.
group, and
So
sometimes that can
can
even
confuse
confuse
you.
you.
It
Yeah.
can confuse you because I remember last time when I was running the Abu Dhabi course in Abu Dhabi. I think this was before the November exam. And
Mhm.
one of the candidates says, we get confused. You should not get confused. We are not teaching you anything. We are teaching you the right way of dealing with it. And most of the med exams are the examiners, we are actually conducting these exams, the live exams, the actual exams we are conducting. So we are giving you the right tips. So
Exactly.
you must have attended a number of courses from people who are not the actual examiners. And honestly, I have seen the names of some of the examiners who have not even set a foot in UK, who have not sort of
Exactly.
dealt with it. So how can you expect this is a UK exam? And this is not about, the knowledge plays a part, but it's all about how to deal with the patients. And this is what in med exams, all our the mentors, examiners are actually been dealing with this for a number of years. So we can only teach you the techniques, the tactics, but we cannot give you the knowledge. And if other courses have taught you something, wrong, I can't change that. Like, for example, every candidate is coming and asking, oh, what is it? They call it
The
the
way,
height
is it
weight
the weight
ratio.
to height ratio, Dr.
The
Yasmin? Because
weight to height
I
ratio.
came across in 1-to-1
Yeah.
mocks as well.
Okay, height to weight ratio. And I said, why you are asking this?
Yeah.
These are the wrong I practice I've been in UK for 30 years. I've never ever asked my patient in any of this, what is your height weight ratio? Okay. I just gently ask, what is your weight? If it is something related with a BMI, you can just ask, what is your weight? So they will be in the script to the role player. If the candidate asks you, you say you are 110 kilos or something. That is extortionate, weight. So that should give you an idea. But if you're taking a height weight, ratio, and sometimes it's not even needed in the query. Also, the other thing is that you waste your time on. In the question, it's written, Janet Jones has come so and so, right? So the candidate comes, oh, hello, how do you want me to call you? Why are you asking call either Janet or Jones or Mrs. Jones or whatever? So you're, literally wasting 1 or 2 minutes there. Like in the normal practice, when you see in the GP letter is there, Mrs. Janet Jones has come with 2 years of infertility and blah, blah, blah. Okay. So she comes in, hi, Mrs. Jones, I'm so and so. Is it okay that, your GP has written to me that you have come to ask about, management of your infertility? Is it okay if I call you Janet? That's fine. Khalas, done. Or you don't have to even ask, what shall I call you with, and what name shall I call you? These are the things which you're not going to catch you marks, but that waste your time as
Wasting
well.
your time, yeah.
Even half a minute is very, very crucial in that scenario.
Yeah,
Okay?
and people in UK, the patients in UK, they are well aware of the term BMI. Like you can straight away ask that, what is your
Absolutely.
BMI? So,
Yes.
Dr. Yasmin has correctly said that whoever has worked in the UK, I've also worked in Ireland. So, you would know that the patients, they actually, with the weight to height and this and blah blah, they would be more confused. Other than that, they are okay with this term BMI. And another thing is, there's no need to say, to be sorry or pardon me to ask about the sexual history, smoking, alcohol, and STIs, right? So no need
Yes,
to be.
yes, absolutely. And the other thing is which I absolutely hate, and when the last exam, I was doing an infertility low ovarian reserve station, and all these candidates, the whole morning and the whole afternoon, 80% of the candidates I had to listen to the two baskets, egg baskets. I've never heard about this egg baskets in my whole career.
And the
It's only
metallic
that I've
spoons,
started
Dr.
hearing
Yasmin, metallic spoons.
it. So
Forceps.
please avoid metallic spoon. Honestly, I've never heard of metallic spoons. So
Yeah.
why to use these wrong terminologies? The patients are very intelligent. You just use your normal, whatever you don't have. They understand ovary, they understand womb, okay, they understand cervix or the neck of the womb. So those are the terminologies that you have to use. So please, some of the courses, unfortunately, you guys are attending, which are giving you wrong, dealing, using the wrong terminology, which I have never ever heard in my whole career.
Yeah.
Okay.
And so, avoiding jargons is very important, but
Yeah.
you need to use the words which, like the words which are commonly used by the patient. For example, forceps and vacuum, the patients know very well about this, right? Epidural, patients are, these words are known to the patient. So you really don't need to give definitions of, or use alternate words for these terminologies. And so, I think that those were all the questions which I needed to answer. There's one question that
I
what,
have
oh,
a question to Dr. Laila. Can I ask you?
yeah, sure.
Yeah, you mentioned that not to say sorry or pardon when we asking about something very sensitive like sexual history. So,
Mm-hmm.
but what about signposting that you are going to ask something personal to her?
No.
Is
Yeah,
that
there's no
okay?
need to say that you are going to ask something personal, right? So we are going to skip that as well, for even for the smoking, alcohol, drugs, and also for sexual history, because the patient is in gynae clinic after all, right? So in the gynae clinic, every history is personal. Everything is
Yes,
personal in
absolutely.
gynae history, right?
Absolutely.
So
Absolutely. Yeah.
you are not going to say the personal words. Just ask that how many times you have sex in a week with, like, or have you ever had a sexually transmitted infection? So I think that should be okay.
Yeah, and also sort of I say, have you have any drug history? Just sort of some recreational drugs. That's it. And that is very much, people understand that. Sexual history, how many times your intercourse, if, as Laila said, it's a gynae clinic, infertility clinic, and this is a regular things that we ask from the patients. So you don't have to sorry about it, you don't have to pardon for it, you have to ask these questions. Okay, if it's part of your script, if it's part of your question, right?
Yeah.
Not that if a patient is 38 weeks gestation or 40 weeks gestation and you're asking, and there's no relation to her drug history, that you're asking about recreational drugs, because as I said, Leila said in the beginning, that you have a template that you have to tick box all that in within the 2-3 minutes or regurgitate it. You don't need that. So just use it wisely, use your time wisely, and what is needed, just utilize it that way. Okay?
And I also experienced that it's candidates, they want to do this the station or complete the 10 minutes by following their own agenda, right? So you cannot do that.
Yes, yeah.
The presentation or the 10 minutes are there for the patient, right? Or for the role play. So everything should be patient or role play centered. Just follow their agenda. Whatever they ask, if they stop you, they ask something, just answer there and then, rather than saying that, okay, first I'll have to, you have a template in your mind, you want to finish that, and after that you will answer the role play question, right? So that is completely wrong. We are not going to do that. And we need to make sure that we are empathetic, and we check patient understanding and every now and then. So do you understand me? Are you getting me? And giving information in chunks, and just mirroring your patient or role player, whatever they are saying, just follow their agenda, so that you are going smoothly in a flow, rather than imposing your own agenda, or you want to finish your station, or you want to say this and you want to say that, right? And
Great.
another thing is, if you have time towards the end, make sure that you summarize the station, and safety netting is very important. So telling about the further steps, that I'm going to book a follow-up appointment for you, or towards the end of the station, you can tell about some red flag signs. For example, in this patient with ectopic or missed miscarriage, you can say about some red flag sign. If you're bleeding heavy more than periods, if you're severe pain, if you're pain in shoulder tips, you should see us without any delay, right? So I think that was pretty much all. I just want to quickly go through the patient safety points which you guys should ask or incorporate in every other station. So calling for help is very important. In some station, you may come across confidentiality issues. Um, for example, in teenage girls who are coming for termination, you can come across that. So you need to make sure that you are confident. You keep the patient's confidentiality. That will mark you pass for patient safety. Another thing would be addressing their cultural and religious factors. For example, Jehovah's Witness, make sure that in patient in stations where there is a heavy risk of bleeding, make sure, or where you're thinking about blood transfusion, that you ask about, you rule out Jehovah's Witness, but do not ask in every other station where it is not needed. Okay. Then audit and clinical governance is very important. So I told you, in emergency stations or where something has happened wrong, you need to ask about, you need to make sure that an incident report has been raised, you have performed the duty of candor, and a documentation is done, right? In surgical module station, you will come across stations where you have to make sure that WHO safety checklist is done, or you should mention it. Then a safe prescription is very, very important. Correct medication, correct dose, and uh, uh, you need to make sure that the medication or the treatment which you are providing is not contraindicated, right? And then, of course, the treatment which you are giving, you should be mentioning the complications. For example, if you are going to perform laparoscopy, so in the consent, it is very important that you should give her like some serious risks, some frequent risks. This is important. And then confirming the patient's results on the report. So in some of the candidate instructions, there might be a scan, there might be a blood report. May you make sure that the report is belonging to the patient. Then prioritization in labor ward, in gynae board, all this comes under patient safety, and we will teach you guys prioritization in our live sessions, and we make you guys to practice with us so that we can prioritize correctly. And so this is why practice is very important, right? So another thing would be then thromboprophylaxis, antibiotic prophylaxis, and drug allergies. So make sure that allergies, in most of the stations you have to ask about allergies, right? So that was all. I would say that in the last 4 weeks, make sure that you practice as much stations as you can. So every day, I would say 1 to 2 hours, practice your study buddy. So they can they can practice 2 or 3 stations with you, and you also practice 2 or 3 stations. So they can mention your mistakes, point out your mistakes, and you point out theirs. So having a study buddy before exam is very, very important, right? And make sure that you utilize that 4 weeks time in polishing what you have already learned, rather than as Dr. Yasmin said, that you think that joining as many courses will help you pass the exam. Rather than that, focus on a mock exam, and whatever your mistakes they point out, make sure that you polish that, and you try to avoid that exam in the those mistakes in the exam, right? So those were the questions assigned to me. I wish you all a very good luck, and if you guys join our course, I will be there. I'm one of the mentors, along with our senior mentors, Dr. Yasmin, Dr. Shazia, Dr. Hassan, and we had a very successful course in November. We had a very good candidate pass ratio, and Alhamdulillah, I took mock exam of 4 students, and all of them scored above 70. So I feel very proud of my students. And your results, when you guys tell us that you have passed the exam, that make us very proud and make us very happy as well. Um, that is our real success. So hope to see you guys in our sessions, and whatever questions you guys have, you can ask us in our Telegram and on our WhatsApp as well, right? So thank you very much from my side.
Thank you very much, Dr. Leila. That was very insightful and really great. And I hope the candidates have got the message what we want to give. So I will ask Dr. Who is next? Dr. Hauer, please.
Yeah, yes. Hello. Assalamu alaikum.
Hi.
Good evening to
Hi,
everyone, wherever you are. So I have few questions. Most of the things have been discussed, but I've been given 5 questions, so I'll go one by one quickly because we are running out of time, and I also have a clinic at 6. So my first question, this is regarding the MRCPI. So regarding my introduction, I am the mentor for MRCPI course. This is the first time I am with the med exam expert, but I was there for the mock exam, and also I took 1-to-1 mock for a couple of students. We are running the Telegram groups daily. So those who are on the group for the OSCE and written, they are familiar with me and Dr. Musarrat. So anyways, let's start. The first question is, how is MRCPI obstetrics gynae OSCE different from MRCOG Part 3? So I would say that both the exams are entirely different. Okay, so for MRCOG 3, as Dr. Yasmin and Dr. Leila have briefed you already, it's module based. There are 14 stations and there is no break in between. Mostly the subject is the same. As we know, this is obstetrics and gynecology. So there's nothing new. There can be fibroid, there can be abnormal uterine bleeding, tumors. The subjects are the same, but the exam pattern is different. Assessment button is also different. I mean, the marking scheme is entirely different. This time, they must be familiar. MRCOG marking scheme has been changed from asterisk points and domains to either pass or fail. And mostly now the stations are coming like 80, I must say 80 to 90% other recalls, mostly in the part 3. So MRCPI OSCE is entirely different. And the pass percentages, I think, must be higher. Most of the candidates pass. Rarely the candidate is stuck. And there is one long case, and there are 7 OSCE stations. Okay. So in the day of exam, the candidates are divided into 2 groups. One group will go for the long case, and the other group will go for the OSCE, and then there's a break because they divide the whole candidates in 2 halves. and from this one group A and B. So they start the exam, and then there is a long break, and then there is another session. Okay. So the long case will either be obstetrics or gynecology case. Those who are from Pakistan or they have done their fellowship in Pakistan, it's more or less the same FCPS-based exam. Like you have long case. In the FCPS, we used to have obstetrics and gynecology, 2 long cases. Here you will have only one, and you have almost 30 minutes or 25 minutes for the station. There is a role player in the long case. So common stations can be, like I can tell you about one of the recalls is there was a station, and some domains will be or modules will be incorporated into one station because it's a long case. So for example, there's a recall that the patient is previous one cesarean. So this is a VBAC, wants to know the mode of delivery. At the same time, she is diabetic and she is obese. Okay. So now you have to cover all these three things in this scenario. And so first half of the long case is that you will introduce yourself to the examiner. There will be 2 or 3 examiners, 2 definitely, or might be 3 in the long case, and they will be the role player. So you will take the history with the role player. The OSCE station, it will be placed on the table. It's written, it's very brief, like 2-3 lines, and then the examiner will later on ask you the questions. So you have 10 minutes to take the history from the patient, and then the examiner will ask you to examine the patient. Then you will be provided with the findings. Maybe if you talk about investigation, maybe the results of investigation. So you have to come to a diagnosis and explain the diagnosis to the role player again to complete the station. In the end, if examiner wants, they will ask you a few more questions related to the station. Okay, so this is how the long case goes. In MRCPI, in MRCOG 3, it's different. There are 10 minutes OSCE stations. In fact, you have only 8 minutes practically because their role player will also speak or the examiner will speak, and you have to be very, very fast and vigilant and very sharp because hard work and smart presentation is very important. To act smartly is more important for MRCOG Part 3. And there's no time to think. There are long sheets of papers, 3 or 4 papers outside the cubicle. So you have to stand and read all that and make your concept, what they are asking, and know that, familiarize yourself with the task, with the name of the patient, get all the information. And then the bell rings, you go inside and you do the station, and the time when it finishes, you come out, you go to another station. This is how Part 3 goes. So this is one difference. In 10-minute station, 6 to 7 stations are there for the OSCE in MRCPI, in which 1 is the labor ward, definitely, and 6 can be random stations, can be mixed ops and gynae. The routine cases which you see every day in your practice, nothing out of blue. So I would say, as my colleagues have also told you, practice is very important, whether you are preparing for MRCPI OSCE or MRCOG 3. Part 3, or if some candidates are taking both the exams at the same time. So practice will make you perfect. So keep on practicing. If you have subscribed to the course, it's very important. It's right that there are some things in some groups or some terminologies like the egg baskets we talk about are not appropriate. I would say read the information leaflets as well. They are very, very helpful, especially for the Part 3, even for MRCPI OSCE, to counsel the patient. And it's brief, and it's very key points are given in the leaflets. So do read the leaflets when it comes to the counseling. For example, for anomalies or medical conditions, even for tragedies like IUFD, stillbirth, or when you have to terminate the pregnancy or malignancy. So read the leaflets as well along with the guidelines. Okay. So this is the difference between the 2 exams. So, and each station for the OSCE is 10-minute station. Differential diagnosis is very important. They do ask about differential diagnosis, and knowledge is also very, very important to pass the exam, whether it's a 10-minute station, because everything you have to cover. For example, there is a scenario, you enter the cubicle and it's written that the patient had a 3rd or 4th degree perineal tear. And then how would you proceed, or how would you manage? Or the midwife has called you in the delivery room for the 3rd to assess the patient, which she has just delivered, and she has noticed that there is an extended tear. So you will introduce yourself. It's a Viva. In the OSCE stations, one is labor ward, this will be Viva. Other stations, there might be the one counseling station either for stillbirth or anomaly. Road pair will be there out of 7 stations. In one station, there will be road pair. Okay, rest will be the direct questioning with the examiner. So you will tell the examiner that you will introduce yourself, go introduce yourself to the patient, confirm the patient identity, assess the patient, then you step-wise, you will go what actions you will take, what will be your immediate action, what will be your further plan, how you will debrief the patient, what can be the complications, firstly, how you will assess. So in that discussion, the staging will come, classification of the tear, then principles of repair, then warning signs, when you will discharge, what information, pelvic floor exercise, all that information, everything you have to tell. Okay, so so knowledge is a must, of course, to pass any exam. So next, coming on to the next question. I hope I'm clear. Anybody wants to ask about this question? Any queries? So next question is, which stations do candidates fail most often in OSCE, and how to secure slot for the exam? Regarding securing slot for the exam, I would say that apply on time, keep your things ready. When the dates are already announced, you can check on the website, and first come, first serve. I don't know what's their criteria, but the sooner you apply, don't wait until the deadline, or if you are not sure you will take the exam or no, make your decision before the exam window is open, so that so this is how you can secure the slot for the exam. Stations which candidates mostly fail in OSCE. Mostly, if you make a blunder, like you just make a big mistake or you get confused. I witnessed one candidate who was not happy with the long case, and she went out of the exam venue crying that I will not proceed with the further exam. So keep your nerves intact. Don't be nervous. This is only exam, which is not a compulsion. Most of us, we take it by choice. So don't make your lives difficult, okay? And anybody who has a good experience or who already has a specialized degree, which most of you have already, and most of you are consultants also, they can easily pass this exam. The thing is, you have to stay focused, and before the exam, 3 months, 6 months, do your preparation and practice the stations so that you pass. Usually, if you don't pass the long case, you fail the exam. So long case is mostly, I think, in medical conditions, we have in the med exam expert course, we have covered almost 16, 17 stations from the maternal medicine. Similarly, maximum stations I'm putting on for the OSCE candidates in the Telegram group. So the common stations we are covering. But the thing is that you people prescribe, but you don't participate actively. So your active participation, your active role is very important for you, not for us. Okay, we are here to guide you, correct your mistakes. So keep on practicing, as Dr. Leila has said, Dr. Yasmin has already explained in detail. So for both the exams, practice speaking, talking is very important. Like one of the mentors used to say to us that talk the template. It's not that you have the template. So I'm not giving you the template, already in the Telegram group. I'm just giving you the guidance, because you have to make your own template. Everybody's, way of talking to the patient is different, and your experience is different. Not all the candidates are at the same level. Some may have less clinical experience, so they are not having working currently, or they have a break in their career and they're just preparing for the exam. And somebody who is at the senior post and who's seeing patients and dealing with the patients day and night will have a different experience and different language and different way of management. Okay, so stick to the guidelines and the protocols you should know. And always I've told that SBAR approach is very important: situation, background, assessment, and recommendations. Similarly, when there is a question managed, so management will include taking some targeted focus history, examination, then going with the investigations, then you will go with the treatment. Okay. So treatment, as Dr. Yasmin said, most of the conditions, they are conservative, medical, surgical, according to the clinical scenario. So this is the basis. So basic history is the same which you have learned in third year, but if you have less time, in 10-minute session, you don't have time to go through all those unnecessary things, you can always omit. Okay. Third question, how should candidates answer communication and counseling stations? Yes, so communication and counseling it's very important that you read the leaflets again and again, again and again. It will take you 5, 10 minutes, maybe 12 minutes to initially to go through one patient information leaflet, especially for the anomalies, how to describe. In some OSCE books, in Koje book, very nicely, he has given lots of explanation for the medical terminologies, like in layman language. So read that, like and carefully, or there are lots of things. I think there are several pages defining how you can explain in layman language. Also in RCOG website, you will find. So first of all, don't use medical jargons. Secondly, familiarize yourself with the patient, and also show your empathy. It's not like you will utter the word that I'm very sorry, and from your face, maybe you're smiling or you're just blunt. No, your body language should be the same as the patient. Soften your voice, talk slowly, listen to the patient, and empathize. If the patient is telling you that my baby, I had a delivery 2 years back and a baby died and I want to open my tubes, you will say, okay. So this is not the way. You have to show your empathy first, that I'm very sorry for your loss and I'm here to help you. And then you go on how you will proceed. It's okay. I'll ask you a few questions to know more about you, and then I'll give you a plan how we can help you with the recanalization of the tubes. Okay. So communication and counseling skills, again, you will be perfect with practicing. Practice with your study buddy. Practice in the groups. You volunteer more and more, because this is a great opportunity. Dr. Yasmin will agree with me that a few years back, this Telegram groups and mentorship culture was not there. There were only few, like I remember Dr. Mustafa was there, one or two people only who were running the courses. And there was UK old teacher, I'm forgetting his name, from Manchester, British, Scottish professor was there. He was doing courses free, and he has been doing for a long time. So this culture is new, but this helps because now the students are gaining like high marks. They are passing with very high marks, like 92%, 87%. This is all those people who are following but it's not only that you join a course, you have to put in your 100% within the course. Be active and
I
participate.
agree, Dr. Khala. I agree. I think we struggled. Our system, it was much, much tougher. We did not have this help like, these students have. All these online courses and all this, mentorship. We would work, and then we would practice in our work.
Yes,
So I
exactly.
remember, the study buddy thing is, we just colleagues meet after with the kids, small kids with us and all that. We did not have all this.
Yes.
So these candidates these days are very, very lucky that they have got this support.
Yeah.
So I think, utilize it to the best.
Yes. Okay. Thank you,
Thank you.
Dr. Yasmin.
Thank you very much.
So moving on,
Any
I am rushing because
questions?
I also have a clinic at 6, so I just want to finish it up. Okay.
Sure. No, thank you very
Nice
much.
meeting
Thank
you. Anyways, I've heard about you, but this is the first time we are meeting. Okay,
Lovely to see you. I think we should, as mentors, we should have a separate webinar and meet together. I think it would be really good. We are in different parts of the world, but it's really nice to meet you, Dr. Leila. This is the first time I'm hearing you guys, or hearing your name, because we all are very busy in our own professions and lives. But I think it'd be really good mid-exam as a platform that, as mentors and examiners, we should meet sometime.
I'm here with Dr. Shazia. She's my colleague.
Oh,
So
Dr.
you must be knowing Shazia.
I came. I did a talk I was there in October. I did in your conference. So I could not meet you because I was there only for 2 days. So I had to go back to Abu Dhabi. But it's a pleasure seeing you, and look forward to meeting you in person.
Same here.
Good luck in the clinic. Thank you.
Okay. So
Who
I
other
have
who
two
is
questions left. I will quickly finish. Just two
sure,
questions left. Yeah, okay.
sure.
So question number 4 is how much clinical knowledge is expected in OSCE stations? So of course you should know the all the clinical knowledge is expected. I don't understand who put this question, because without knowledge you can't pass the exam, right? So it's not that only you will communicate. What you will tell the patient goes according to your guidelines. The For the Irish exam, there are Irish guidelines, but there's not lots of Irish guidelines are not covering all the topics. But we expect that in the exam, the latest guidelines, they are already on the website. We are also searching, and we are putting in the study material group. There is a support group in which I'm putting the leaflets related to the topic, and I'm putting the old guidelines as well, talk articles, because some stations which are coming in the MRCOG free exam, they're also coming sometimes in MRCPI exam. So important TOG articles also we are sharing. And so knowledge is of course required. How much? I think there's no limit to the knowledge. So but make sure when you're sitting an exam, you have the basic knowledge of a topic. Okay. And also for most of the conditions, for example, there is an abdominal mass, so you should know the DD of the abdominal mass. If it is a fibroid, you should know its management. What are the signs and symptoms? What things are important in the history? So always history, HOPI, history of present illness is very important. And then related to her symptoms, not like if she has menorrhagia, so you will ask about how long the periods stay, how much is the flow. Just we want to know the severity of the condition, how it is affecting her quality of life, and does she have any anemia symptoms like fatigue, shortness of breath, things, palpitation. So knowledge is very important. So we cannot measure how much, but you should have the basic knowledge. And for the postgraduate, this is a postgraduate exam, so your knowledge should be up to date. How can candidates use feedback from mocks to improve? This you people should tell. I think feedback from mocks, even from the day-to-day practice, feedback is always very important in any matter. If for me also feedback is important, how I teach or how I discuss, what are my shortcomings. So feedback always helps you. Feedbacks are not to criticize, and don't be shy that, oh, maybe this will be my mistake, or I will not do this station properly, I don't know, or how to do it. Just do it, and then together we will come up with the best management, or with the best template, you can say, of that station. So feedbacks are really very important. This feedbacks are given for you to make improvement, to point out what we have missed. We all make mistakes, how we can do the things better. So this is the aim of feedbacks, So feedbacks are, of course, very important in the mock exam, definitely, because why mocks are done? Mocks are done for you to go through the drill, which you will face in a 2 days or 3 days time in the real exam. So once you will go through the drill, and if you will do very well, you will be more confident. So it will enhance your confidence. And also, if you are doing some mistakes, they will be pointed out, so that you cannot do, you will not repeat. Especially for the labor ward prioritization, it comes both in MRCOG and in MRCPI also. So if your priority is wrong, or you are taking too much time in one station, so you will learn how to improve. Similarly, communication tasks like counseling or breaking bad news for anomalies or malignancy. So attending a mock, I think it's a must for everyone. And how many mocks you should do, this depends upon how well you are prepared. If you are very well prepared and you have been practicing in 3 months, 6 months time, then only one mock is sufficient. But if you are not, and you're not sure and not confident enough, then, and you have lots of money, then you can do more than one. Okay, I hope I've answered all your questions. Anybody wants to ask anything? Okay, so I think I'm done here. So over to the next mentor, please. And bye-bye for now. Goodbye to everyone. Okay?
Thank you very
Nice
much. Thank you,
meeting you.
Dr. Laura. Thank you. Bye-bye.
Okay. Bye. Bye.
Who is the next mentor? Can you just please, Dr. Musarrat?
Yeah. Assalamu alaikum, Dr. Yasmin. I am Musarrat. And I think I
Walaikum.
am the last one to answer the question of the candidate. First of all, thank you very much, all of you who are sitting in this cold weather since long time. And as we are running out of time, I will shortly answer your question that were being asked. I think all of questions are already answered by my seniors. So first question, how long should candidate prepare for MRCPI, OSCE or the written exam? I think this is the most difficult question to be answered. Each of every one of us has difficult circumstances. Some of us are working or doing the training, and most of the time they spend at their job. Then at the we have family, kids, and different commitments. So there is just to say 6 months, 3 months, 2 months. It's very difficult, and some are very quick learner, and some are very slow learner like me. I usually need 1 or 2 or 3 revision to memorize anything or to understand the things. So it's up to you. If you have enough time that you can give to your study, then it will be you may prepare yourself in just 2 or 3 months. And I will suggest those who are going to planning to appear in the OSCE exam and they are working, you should think each and every patient you are seeing in your daily clinical practice as your exam candidate or a role player or exam case. Think that this is the case that will be in my exam and how I will proceed. Then it will not need any special time to prepare yourself for the OSCE. This will be things will be in your reflexes. You will answer the question or you will proceed or take your case very smoothly and very nicely. Then second question is that how should answer be structured to score well in the OSCE? So your answer should be structured. This is a very good question. First of all, you make agenda, some few opening sentences, then what the stuff or the content in between, and then close your station. Summarize your station as well. So time management is very important in this structured discussion as well. Instead of structuring your answer in sentences, structure the answer in the boxes. Like assessment of the patient, this is one box. I will assess this. Information gathering is another box. Like patient with a heavy menstrual bleeding, I will ask how much pad she is using, how it's affecting her quality of life, intermenstrual bleeding, postcoital bleeding, symptom of anemia, family history of the cancer, or her future fertility plan as well. Few things that are very important relevant to your case. Always focus on your case, not just pour the knowledge or vomit your knowledge there. So this is very important that you should relate your answer to the scenario and read the scenario very carefully. Next question is that what mistake may make candidate lose marks in the OSCE? Actually, I am not examiner, first of all, to be very honest. But I know that we are making the most important thing is that sometime under stress, we are not reading the scenario very carefully. And we are missing the things while reading the scenario. And from here, we are starting our mistakes. काम यहीं से खराब होना शुरू हो जाता है. I'm sorry. That we are not reading it carefully, then we are not listening to examiner what he is asking. Believe me, examiner are not there to fail you. They are there to pass you. Okay. So sometimes we are going or we are detracking and they are asking the question. Even role player is asking the back to the carefully to the examiner and to the your role player as well. Okay, then how can candidates stay calm and confident during the examination? Okay, this is another important question. To stay calm and confident is very important. Confidence is will come by your preparation. If you are well prepared for your exam, you will be confident. Usually, candidates are anxious because of fear of or phobia of failure. This is not the end of your life or end of the world. So if any one of us will fail, what will happen? Nothing. we can reappear. So please remove this fear or phobia from your mind that if you will fail, what will happen. I know each of and every one of us has invested time and money in these exams, but your confidence and your calmness is very important. But and most important thing is examiner are not there to fail you. Candidate think they are there to judge them. Obviously, they are there to judge you being a doctor. Are you safe doctor or not? So stay calm. Inhale before entering in the cabin. Inhale from the nose and then exhale from the mouth. This is a very um, suitable yoga asana. It will slow down your adrenaline. You will be calm. Number two, read the scenario very carefully. Number three, it's not important that you have knowledge and you interpret your knowledge there. It's the most important thing is engage your examiner. When I appeared in the exam, really it's true that my examiner, she was sleeping. Okay. So it's very important because they are human beings. Since morning, they were sitting there and listening to the candidate, their blunder, their mistakes. So they are tired without any break, without any tea or coffee. So it's most important thing is engage your examiner. Okay, because keep an eye contact with them. This is very important. And how can candidates stay calm? This I have answered. This is very important. You should stay calm. Whatever you know, you recite that. And before going entering in the exam, pray for yourself. Ask your mother to pray for you. This is very also very important. And what final advice would help first time and the repeat candidate? Those who are appearing for the first time in the exam, they are very well prepared, and usually they will overdo in the exam. And one thing I think examiner, they don't like the overconfidence, and they make the mistakes. And those who are appearing as a repeat candidates, they have their morale is usually down, and they have less confidence as compared to those who are appearing first time. But I think those who are appearing second time or even for the third time think that as they are appearing for the first time, enter in the exam with without any preoccupied mind. And one more thing I would like to say that examiner are there to pass you. So be positive, entering the exam with the positivity. Okay. Thank you very much. Thank you for your time. If any question, we have live session and you can ask them there as well. Thank you, Dr. Yasmin. You want to add
Thank
anything? Are you agree with
you.
me? Examiner are there to pass
I
the.
do, I do agree with you. And you know, the thing is that as you said, the examiners get the examiners engaged, and it's very, very important because we are in Abu Dhabi. We have a 2-day exams, and we start from 11 o'clock, and we are sitting there till 7:30, and we have 2 sessions. So imagine the candidates going through, and you're listening to the same rigmarole. It can be very boring, although we are very alert to give you the maximum marks. We are there to pass you, honestly. I'm just sort of listening intently, and every examiner colleague, they are intently listening to mark you. There will be some examiners a bit tough, but most of us are doves. We are there to help you and to mark you. So please cash those marks. Please avail that and engage us. Yes, as Dr. Musarrat said, that we don't like arrogance. There are candidates who come arrogant and they have a zero knowledge and zero communications and zero interaction with the patients. So please just sort of be yourself and do whatever you are normally doing in your clinics. If you come and you're arrogant, that tells us that this candidate is not safe. This candidate must be doing the same in their clinic. So if you don't have knowledge and you cover it with arrogance, that is very bad recipe. So I do agree with all the my colleagues so far have said. And if there's anyone else, anybody wants to comment, otherwise we can just wrap it. So I will, I would sort of say, before we wrap, I would like to leave you with just few thoughts. And I think most of my colleagues have said it's important. Take a moment when you go in to recognize what you have been given, what tasks you have been given. You are not alone. You have got other colleagues, you have other candidates, they are in the same boat. MRCOG Part 3 is not asking you to be perfect. Okay, no one is perfect. We are not perfect. It's asking you to be safe, calm, and human. Be yourself when things are uncertain. In many ways, it's simply asking you to do what you already do in every day. And I think every one of us said throughout the evenings that you need to be yourself. These are the things that you normally do in your clinics, but put it in a structured way. In examinations, we want it in a structured way. Okay. And you have heard today from all these mentors about communication, escalation, putting the answers in a structured way. If you take one thing from this evening is into the exams, whichever exams you are doing next, let it be this, that you are not there to impress anyone. You are there to look after your patients, and we want safe doctors who can look after the patients. And mind you, if you feel stuck in a station, slow down. Okay, if you feel unsure, ask for help. If emotions are very high, acknowledge them, right? So these are not exam tricks. These are the behaviors of a good doctors. These are the behaviors of a good clinicians. And that is exactly what this exams rewards. That's what this exams is asking for. So I would say that trust your preparation, okay? Trust your judgment, and walk into each station calmly, steadily, unhurried, and grounded. Don't show that arrogance, as I said earlier on. And do the right things in the right order, and let go of the rest. Whatever negativity is in your head, just let go of that, okay? Own this exam. You belong in that exam, and very soon, inshallah, you will be looking back on it from the other side, where we are sitting, where my mentors are sitting. You will, inshallah, join us from this side. So with this, I wish you all every success, and we genuinely look forward to, inshallah, congratulating you when you are done, and we'll be hopefully celebrating with you. So thank you all, and good luck, and have a lovely evening. And if you have any questions, any queries, please do not hesitate to ask us. Okay.
Thank you very much, Dr. Yasmin.
Thank you
Allah.
very much. Allah Hafiz. Good luck. Bye-bye.